Yeah. Good afternoon, everyone. Thanks for being here today. I have the special pleasure of introducing a dear friend and colleague, Dr. Michael Savona. Michael's had a fascinating background. In addition to all the things I'll tell you about that he's accomplished academically, he served 13 years in the Air Force. As an active duty officer, did tours in Iraq as well as other parts of the world, and so I think particularly impressive to add that to your CV. But Michael, as a medical student at Wake Forest, enlisted in the Air Force at that time, finished or continued his residency and clinical training in California. He was based at Travis Air Force Base and had clinical experiences at both UC Davis and UC San Francisco. He then did a brief stint at the NIH, followed by a fellowship opportunity with Sean Morrison at the University of Michigan. And you guys from the stem cell crowd know that Sean's one of the preeminent stem cell biologists in the world. And so Michael had a wonderful experience there. He then went off and did some of his military service, being stationed in San Antonio, working at the University of Texas, and as I said, touring overseas. He then had an interesting experience for about 3 years. He served as research director for hematologic malignancies for the Sarah Cannon Research Institute, which is one of the largest private clinical research entities in the world, and gained some tremendous experience that he brought back to academia in 2014 when he took his current position at Vanderbilt University, where he's an associate professor and the director of hematologic malignancies early therapeutics program, as well as hematology research. And so bringing to bear some tremendous skills in clinical research, along with his interest in translation and his own laboratory at this stage, he's been able to bring forward some really fascinating concepts in the sort of translational space in heme malignancies and his personal interest in AML. And so what he's going to tell us about today is some of the laboratory work around MCL1 and how that translates to clinical impact. So Michael, thank you so much for being here, and thanks for wearing that nice hat we gave you.
Good morning, or I guess afternoon now. Craig, thank you for that very kind introduction. I do not have the typical career path, that's for sure, and I'm mature enough to realize that it's actually happened for a reason now. So hopefully these things will lead to ultimately better treatments for folks. I'm so happy to have this Buffalo's hat. My wife went to CSU, so I'll be sure to wear this home off the plane. Yeah.
You're going to be sleeping on the couch.
Yeah, I might be, but it's worth it. I'm, this is an informal place, so I'm going to wear my hat during the talk. That's all right. In support of University of Colorado. So Vanderbilt's a kind of a similar place to Colorado, and I actually talk to people a lot about the similarities between the two. We have a similar encatchment. You got to go a long way before you find another comprehensive cancer center, and for us, it's not quite as far, and there's less goats and cows and more people, but it's similar in that we're kind of serving an area, taking care of trying to do lots of different things, trying to be, as an institution, a jack of all trades, and that's kind of important. I chose this little snarky title, the ABCs of MCL1 and BCL2 and AML. But really, I want to address what I think is a paradigm shift in the treatment of leukemia. We're at a point right now in the treatment of AML where things are changing and haven't changed in 40 years, and the University of Colorado is at the tip of the spear there. So the work that, and I'll acquaint those of you who aren't familiar, the work that Dr. Pollier has done and Dr. Jordan have done, but the work that they're doing is right at the forefront, and they're continuing to push this envelope and make these things available to people. And everything we do in biomedical science revolves around how we can make the biggest impact. So that, for me, is very exciting. Okay. These are my disclosures. I take money from people who have it. And I have ownership stake in Karyopharm, and I'll mention Karyopharm at the end, so that's worth noting. Okay, so everybody's familiar with this. It'll take me a minute to get used to this mouse, so sorry. The hallmarks of cancer, so the Hanahan and Weinberg paper, a famous paper, probably the most cited paper in oncology in 2000, reviewed the hallmarks of cancer. And you'll notice there, resisting cell death is a hallmark of cancer. In 2011, when they wrote this paper again and thought about some new things that we've learned, not only did they recognize that resisting cell death was still a hallmark of cancer, but they recognize now, hey, since 2000, we've developed pro-apoptotic BH3 mimetics. And I'm just going to spend a moment on this slide. So Tony Latai at the Farber is one of the leaders in the field, and since he trained with Stan Kortsmeyer, the late great Stan Kortsmeyer, in his postdoc, and really developed an understanding of how cells die. He's gone on to be a leader in trying to identify different type of cancer cells on what their reliance is in anti-apoptotic proteins. And I just want to, just to get everyone on the same page, acquaint folks with this cartoon in one of his reviews, which I find to be fairly informative. So in the setting of a death stimuli, the activators of apoptosis are supposed to be activated. The anti-apoptotic proteins, including namely BCL2, BCL-XL, and MCL1 in leukemia are the main ones, are supposed to be slowed down. Sensitizers are supposed to be upregulated, and effectors are supposed to be activated. And what happens is anti-apoptotics are bound at the BH3 binding site with sensitizers, which then free the activators, which then bind with effector molecules back and back and lead to oligomerization of those compounds and ultimately cytochrome C release and mitochondrial outer-membrane permeabilization. Tony's probably got 10 reviews in high-impact journals you can read if this is not an area familiar to you to acquaint you in more detail. In cancer, these immortal proteins tend to have a very dominant role, and Dr. Weinberg alluded to this in Hallmarks of Cancer in 2000 and then in 2011, and this will be the focus of my discussion today, and really what I think is an absolute paradigm shift in the treatment of leukemia. So the first attempts, with BH3 mimetics, were with two compounds, 263 and then 737. And ABT263, which was developed in my collaborator's group when he was at AbbVie, Stephen Fezzik, who was the head of discovery there for a couple decades, is a small molecule potent inhibitor of BCL2, but it also inhibits BCL-XL. And this co-inhibition of BCL2 and BCL-XL in these cell lines, you can see in various different tumors, leads to a fairly aggressive dose-dependent growth inhibition. And in this, ALL cell line, you can see complete abrogation of the leukemia. Also, though, in the in vitro, it was discovered. It was discovered fairly early that there's a dose-dependent, 263 concentration-dependent thrombocytopenia. Nonetheless, this was tried in clinical trials, and this is a paper where the drug navitoclax was first tried in patients, and these are different dose regimens. But what you can see on the far left hand of the curve is a dramatic, immediate disruption of thrombopoiesis and thrombocytopenia. So, ultimately, this talk isn't about BCL-XL, but I just wanted to make the point that this is running into real developmental problems because of the thrombocytopenia that's induced. What's kind of funny is that it's taken a decade to figure out this is probably a great drug for people who have thrombocytosis, and it's now being explored in myeloproliferative neoplasms, particularly people who have proliferative platelet disease, like ET or MF with thrombocytosis. So along came ABT199, which was published in Nature Medicine by the AbbVie group, the same group that Steve came from, and now Steve is a professor of medicinal chemistry, biochemistry at Vanderbilt, and I'll show you some of our unpublished work in a moment based on our work with MCL1 inhibition. But The ABT-199 was the first attempt at developing a specific selective BCL2 inhibitor. And you can see in the variety of both hematologic and non-hematologic cell lines a very potent molecule, which this is on the y-axis is measured in micromolar, where 100 micromolar is considered potent, and you have several cell lines that are killed by single-agent activity of ABT-199. Within 2 years, there's a publication in New England Journal. So this is a very fast development path. This is how exciting this was. And I don't want to belabor a lot of the CML or the CLL work, because that's not what I talk about or study. But in CLL, which is an entirely MCL1 dependent disease, every patient pretty much, with little exception, had response with lymphocyte count, symptoms, and node reduction. So it was a remarkable advance, and this quickly has become approved for 17p deleted CLL, which is a high-risk CLL, which has a median survival before this drug measured in months. In AML, this was explored and published in Cancer Discovery just after the original publication, and this is a Tony Latai's group and others, where I always like showing these luminescence assays because I think they're kind of fun. But you can see that the vehicle-treated mice clearly developed leukemia by day 14, where the ABT-199 treated mice have a far lower leukemia burden, with some mice really having no evidence of that tagged bioluminescent leukemia at day 14 at all. And the survival is improved, statistically significant, although you might say that's not many days different, and we'll get back to that in a few moments. Now, I don't want to get too deep into this because this starts to exit my universe and enter Dr. Jordan's, but sensitivity to venetoclax is relatively independent of the mutational status. And we knew this in vitro very early, where these are all patient samples, several patient samples were tested in Tony's lab, and you can see that patients' samples with IDH or NPM1 mutations or NRAS mutations had variable responses. So this was attempted in the clinic, and Dan Pollier, and I spelled your name wrong in the credits, that was in a 10 font late at night last night. Sorry about that, Dan. Dan was one of the leaders of this study where the drug was used as a single agent for relapsed refractory AML patients, and unfortunately, folks didn't do so well. But we did see pretty early a sign of BCL2 sensitive through this protein marker that was used in the study. Now, I'm going to talk a lot about protein markers of anti-apoptotic proteins versus BH3 profile in a minute, that those patients did a little bit better. So quickly in the clinic, this led to two very important studies that were just completed. One study that was led here, the venetoclax in combination with DNA methyltransferase inhibitors or hypomethylating agents, azacitidine and dasacitabine. I believe the MD Anderson people took the dasacitabine and you had the azacitidine, so Ford Chevy, as we say in the South. So you took the Ford. We did the study of venetoclax in combination with low-dose cytarabine, and all the studies showed pretty much, and Steve Strickland's my collaborator at Vanderbilt, and all the studies pretty much showed similar results, but since Dan's published, I'll present his. And this is really a practice-changing landmark study that one of your own published here in January. So the way this study was conducted was in a ramp-up, and we learned very early in the CLL study where patients were advanced to higher dose in a typical 3x3 study to begin with, and we had 2 grade 5 toxicities from tumor lysis. That means those patients died from the complications of tumor lysis syndrome, meaning their tumor died so fast their body couldn't take care of it. So usually tumor lysis is a good problem to have, but it's not when people develop hyperkalemia and death. So after a short break, that study was restarted with this ramp up, and that's how the AML study was conducted. Now, as it turns out, there's not as much tumor lysis in AML as you might think. It's much more common in CLL, and that might be for the reason that I mentioned before, that CLL is entirely BCL2 dependent, and AML is not. But this was ramped up in 4 different dose cohorts, as you can see here. Group A was the group that received azacitidine in Houston, and I guess azacitidine up here and other places. And this is the remarkable thing, and I'm not presenting the data for the low-dose RSC trial because it's not published yet, it's in process. But the complete remission rate is unlike anything that we see in patients who can't get chemotherapy, and frankly, approaching what we see in good risk, core binding factor mutated, c-KIT negative AML in young people, 70% CR, CRI. CRI meaning absence of leukemia in the marrow with failure to recover counts fully. And a lot of those patients with CRI are patients who have platelets of 99,000, which is perfectly indistinguishable from anybody in this room, and no longer has AML, but that counts as a CRI. And then there are patients who have transfusion dependence and have absence of the leukemia. So those are kind of 2 different players, but unfortunately we're stuck with the IWG criteria. What's important to know, though, is that not only are these responses and a high frequency, but many of them were durable. And we've shared stories of patients that we've had on for several years. I have one patient whose biggest complaint after he drives 6 hours from Bristol, Tennessee is, do I really have to come here every month to get my pills? I said, if you want them for free, yes. So, the durable responses, and I'll be a little provocative here because we don't have all this data yet, but we think those patients are those who are more BCL2 dependent, or at least were BCL2 dependent at the time that they were primed with their azacitidine, decitabine, or in my case, low-dose RSC. So getting back to the original phase 1 study where patients were given single-agent therapy and not primed, BCL-sensitive cells, or BCL2 protein levels, I think, greater than 35% of the total anti-apoptotic protein were counted as BCL2 sensitive. Those patients just did better. Now, we know that the BCL2 family protein expression is extremely heterogeneous in AML. I'm going to show you a bunch of unpublished data from my lab in the next several slides. This is an assay we conducted to just basically see what were the protein levels in basically all AML cell lines that we had and a couple of lymphoma cell lines. And you can see that there are very few, if any, that have absent one of these anti-apoptotic proteins or another. And in fact, most of them have multiple anti-apoptotic proteins, but seem to have one that's dominant over another. We conducted BH3 profiling on the past experience of Marina Konopleva from the study that Dan conducted. Dan was the second author on that paper. And Tony Latai has been doing for years. The cytochrome C release assay is fairly reliable. And when you use peptides that are consistent with MCL1 engagement, there was in that original phase 1 study a consistent reliability between the time the patients were on study and how much cytochrome C release was present in the presence of those MCL1-dependent peptides. So that was, an R-squared of negative 0.75, so probably the strongest correlation found, if I remember correctly, in that analysis. And it's difficult, as I'll show you in a moment, to actually predict which patients are going to respond without this type of in-depth profiling. So, going back to our work in MCL1 at Vanderbilt, so Stephen joined Vanderbilt 7 years ago, quite just before I got there, and he was recruited to build a university-focused medicinal chemistry unit and develop new drugs in collaboration with industry. And we've since, this is the first compound that's now been licensed to Boehringer, and that I'm telling you about, one of the tool compounds today. This was the earlier compounds we used. This is 158 and 159, and we very quickly showed a very strong Spearman correlation between the MCL1 dependence and growth inhibition in cell lines, feeling like we had on-target effect. And likewise, this was seen very clearly in the histograms on the left with respect to sensitivity. Now, this is not a very potent inhibitor. So some work was done to optimize MCL1 inhibitors, and I hope there's no medicinal chemists in the room, and if there are, and there probably is one, so I'll just keep it at these figures, because I'll suffice it to say that the way that the structures are designed by Stephen and what he's kind of gained his acclaim on is structure-based design. So for a simple clinical biologist like myself, I like to think of it as, instead of having one drug that's just supposed to fit in, he's got a box full of Legos and puts the pieces together to fit which pieces will fit each of the binding grooves in that particular protein. And that's led to successful development of several drugs, including 263, 737, 199, and now the MCL1 series that we're talking about. And this is the inhibitor that I'll be alluding to. Oh, and I'll just refer to it from here on out as 013. So in our hands, unlike BCL2 protein, MCL1 growth inhibition is completely independent, at least in our cell lines, of relative protein levels. And it's a little more confusing with BCL2, as several have argued that there is some, I'm sorry that slide cut off there. Cut off on the screen? Yeah. So that Spearman is something like negative 0.7. But I don't think it's useful, these kind of assays are useful clinically to predict by protein level who's going to respond or not respond, but it's statistically significant to show that in the lab, more or less, your higher protein amounts lead to more response. Unlike MCL1, where it's completely all over the place. Again, this is what I was alluding to with this. With the other inhibitors, with 013, this correlation grows even stronger, and we identified our AML cell lines to work with based on which had the greatest relative cytochrome C release and growth inhibition, which in this case were MOLD13 and MV411. H929 is a completely MCL-independent myeloma cell line, which is one of the reasons that this is being explored clinically in MCL1, or in, multiple myeloma. So it turns out that pretty much all these cell lines respond to MCL inhibition, which is actually, with this tool compound, which has been advanced many series beyond this now, is much more potent in the same cell lines than ABT199, which was encouraging and interesting. There were 3 cell lines that didn't respond, and these are listed on your right. And you'll note that from a previous slide, these all had relatively high levels of MCL1 protein, except for the KG1. So not very reliable indicator of response. So we went on to attempt xenograft transplantation with the MV411 cell line in mice. And for those of you not familiar with these experiments, we radiated this immunocompromised NSGS mouse, which is an extraordinarily immunocompromised mouse that very well engrafts human hematopoietic cells and is used to actually make humanized mice now for those solid tumor people who are playing around with these hematopoietic models. So we let the leukemia engraft, and then after 14 days started dosing with VU013, and then did weekly detection for chimerism, and ultimately necropsies when the mouse died. And you can see here that this drug has a very nice dose-dependent reduction in 33 positive, 44 positive cells, human CD33 positive, 45 positive cells, which are the immunophenotype of the MV411 cells. That's in the blood, the bone marrow, and the spleen. And if you look at the immunohistochemistry, you can see very nicely that the brownish, orangey, or burnt orange if you're from Texas, cells start to disappear in the bone marrow altogether and are there and really faintly in the spleen in that big dose of 75 milligrams per kilogram. But unfortunately, these mice all died, and they died around 45 days of leukemia. This p-value is not here, but it's statistically significant. And in a mouse model, this is actually clinically significant for those of you who don't deal with these mice, that 10-day difference is meaningful, but it's not enough. And the question is why? So we took the cells from those mice that died, and we plated them in vitro and treated them with VU013 in vitro. And the MV411 cells that were remaining in those mice at the time of resistance and death of leukemia were this orange bar here. they were almost entirely resistant to VU013. And just because science is the way science is, the gray bar and the black bar don't match. But basically, this is the naive MV411 cell line, and this is like virtual reality. This thing is kind of tricky. And the gray is, the vehicle cells, which for whatever reason they were immunosurveilled in that mouse and had a little bit different response rate than the naive MV411 cells. And this actually happened vice versa with BCL2 as well. So then we went on and tried to see if we can artificially create resistant cell lines, and dosed both MV411 cells with low-dose venetoclax and another set of MV411 cells with low-dose 013. And over time, when we developed these resistant lines, you can see that the MV411 lines that were VU013 resistant were then more susceptible to venetoclax in the red as compared to the gray, and the venetoclax resistant lines were more susceptible to 013 than they were prior to being made resistant, which indicates, again, indirect evidence that there is a resistance that's borne out through another anti-apoptotic molecule, specifically MCL1. We went about to prove this directly and did BH3 profiling on these cells. And what you can see here, I won't get into the technical reasons of why we used ABT199 instead of peptide for BCL2, except to say that it's just a better reagent to use. You can see that even at low doses of ABT199, the parental MV411 really didn't have any didn't have significant BCL2 induced cytochrome C release, or BCL2 inhibitor cytochrome C release, but the resistant line was entirely. I'm sorry about this. I'm not very coordinated. It's like in the mirror. The resistant line in the presence of ABT199 was extraordinarily sensitive to the BCL2 inhibitor. Vice versa over here, not as poignant, but certainly clear with the MS1, which is the MCL1 focused peptide, where the parental lines were of MV411 was MCL1 dependent, and then as the resistant lines were less dependent, seen here, even at super high doses of 30 micromolar of MCL1 peptide. So the obvious next step was to try to decide if there was rationale for combining these two steps together. And if you look at this kind of poor man's combination index GI50 chart here, you can get a sense that there might be cell lines where you might establish some pretty exquisite synergy. There might be some, like the second cell line, U937, that is a head scratcher, that is not responsive. Can't draw a line. I'm glad I'm not taking like a DUI test right now. U937 that is resistant to all of these specific inhibitors. And I'm not sure why that is exactly, unless this was a BCLW or A1-driven tumor. And to be honest with you, I failed to actually fully characterize that, so I can't tell you. But I will tell you that in combination, there's synergy pretty much in all the lines, and a representative cell line is the MV411 cell line to your right, when you can see with little itty-bitty doses, these two drugs together are very effective. And there's the resistant cell line, U937, where it doesn't really make a hill of beans difference to have the two drugs together. So I'm not going to show you the MV411 cell line, but I will show you the PDX experiments. We did several PDXs from patient-derived xenografts and treated those NSGS mice that had been grafted the AML with both VO13 and venetoclax at subtherapeutic levels. And that's really important to note. There's a theoretic risk that if we block anti-apoptotics entirely, we won't give cells a chance to survive the normal noxious stimuli that may occur with slight infections or turbidity of blood flow in endothelial cells. There's a potential signal in cardiac tissue. So I used very low doses here that were not able to show a response as single agents. And in fact, 25 milligrams of VU113 and 15 milligrams of ABT199 led to very poor reduction of the leukemia, whereas we only had 2% of leukemia engrafted at 6 weeks post-transplant in this model. And you can see that the reduction of the leukemia was present not just in the blood, but in the bone marrow and spleen, as evidenced by these histograms and by the immunohistochemistry. Now, you know, those two bars on the right that indicate there's not much difference between VU013 and the combination is a little bit of a head scratcher and makes me wonder what the therapeutic index is. And those experiments are ongoing, giving VU013 in higher and higher doses. We never met the MTD with either of those doses in the mice. So either of those drugs in the mice. So those doses are being expanded to see if the therapeutic window can be defined. We wanted to see if BH3 profiling, like it did in the cell lines, predicted response in patient samples, and indeed, there is variable, and I'm sure that some of this work has been done here, there's variable differentiation in cytochrome C release in the presence of specific inhibitors to indicate MCL1 dependence, shown here, where the patient 001 has virtually little or no MCL1 dependence, and patient number 3 has considerable MCL1 dependence, as well as patient number 2. And if you look at the co-IP on the bottom right panel, you can see that AML1, in fact, has BIM bound to BCL2, and and patient number 2 has MCL1 more differentially bound to BIM. We also took patient samples, and I have to apologize, the way this is represented is very confusing, and it didn't occur to me until after this was in PDF form and I couldn't actually alter the graph. So the person who did the majority of this work is wonderful, but this is off. So while I'll acknowledge her at the end, this is a slap on the wrist. So these are from patient samples, and remember, we did the low-dose Ara-C and venetoclax study at our place, but companies are funny about taking patient samples and doing work on them unless you're contractually obligated or allowed to do so. So we have a very burgeoning tissue bank, as you do here at your university, and we collected samples separately. And we also collected samples on patients who received low-dose Ara-C and venetoclax off study. And believe it or not, this is becoming a more common practice because remember, venetoclax is approved for 17p CLL. So I have community physicians now who are calling me, asking me how I should dose venetoclax for their ALL patients, which is interesting. But if in the patients who do fail, and we don't have a lot of them, but in the patients who fail, we took the diagnosis sample of both of these two patients, AML 003 and 004, and we treated them both at their samples at diagnosis with the combination agents of both agents, and showed that it was a pretty impressive log reduction of cells. But if we took the cells after failure of the venetoclax and combined with VU013, you have essentially a complete abrogation of leukemia. And this is just a couple patients. We have more patient samples now. So I'm going to be provocative over the next few minutes and talk about what these observations have led us to think about. And you know, heading into the end of 2018, I say 2019 plus because in 2018, venetoclax is likely going to be approved by the FDA in a compendium listing for AML. And once it's approved for AML, it's going to be used on label and off label for AML for different indications of AML in a variety of different ways. So the question is, if we use venetoclax either with a priming agent or not in BCL2 dependent, noted by these purple cells, leukemia, if we find out up front if the patients are BCL2 dependent, should we give them venetoclax and then see how they do? And if they relapse, test them again, and presumably this will be MCL1 dependent disease, and then treat them with an MCL1 inhibitor, either a direct MCL1 inhibitor in clinical trial or a drug that acts as an indirect MCL1 inhibitor that's now available on the market. There's a lot of indications coming out of Denver and our place in Australia that priming with BCL2 not only will lead to long-term disease-free survival in some patients, but may lead to cure. And there's some reasons for this, excellent systematic work showing the rationale why this might be the case coming out of the Jordan lab. We worked on Lotus-C. Some folks are working on idarubicin in Australia, and you folks are working on DMTI in combination. But there's also, in clinical trials, IDH inhibitors, Aztec 727 and CC46. We have a trial with Aztec 727 and venetoclax, and that's an all-oral decitabine plus venetoclax regimen, which we're very excited about because not only is it part of the changing paradigm, but it's all oral. So I still have to deal with my patient from Bristol who drives 6 hours to pick up his pills, but I don't have to deal with him being in the hospital for a month. Similarly, with MCL1, are we able to inhibit MCL1 with a, as noted by these red cells, an MCL1-dependent cells? Are we able to inhibit MCL1-dependent cells with an MCL1 inhibitor and then watch to see BCL2 dependence emerge, or not in the combination of priming like we've seen with BCL2? We don't know what's going to happen when these drugs are given together because the MCL1 inhibitors are in phase 1 right now in dose escalation trials. And presumably those phase 1 dose escalation trials will have results similar to those that Dr. Pollier saw and was published in Cancer Discovery at the end of 2016. Disappointing, but clues to why patients respond and not respond based on their anti-apoptotic profiling. Likewise, there might be novel inhibitors that we can contribute with, can combine with MCL1 inhibitors. But I'm going to kind of be further, even more provocative and ask, can we really engage, the apoptosome in leukemia, and is this a mutation agnostic process? MCL1 plus BCL2 inhibition has promise, in my eyes, is probably the direction this needs to go. We've done some work in the laboratory. I'll show you one particular compound that we had some clues that this might be involved in MCL1 degradation, but we had no idea how it would work with venetoclax. SINE are selective inhibitors of nuclear export, and this is the company that I have equity interest in, so I should disclose that again. SINE compounds, they are the inhibiting XPO1, which is the cargo protein for largely all the tumor suppressors and many mRNAs of oncogenes coming out of the nucleus into the cytoplasm. And interestingly, as cancers become more dysregulated, this transcripts for this protein are upregulated. You see more XPO1. And inhibitors of nuclear export through this mechanism have been successful in phase 1 trials, and the readout for the latest myeloma trial is just positive, so they'll be filing as well. They just received special dispensation from the FDA. Now, the mechanism specifically for MCL1 that we were thinking was EIF4E is one of the one of the proteins that, and it's a carrier protein in its own right. It's kept in the nucleus until it's exported out through XPO1. So we looked to see what the carrier mRNA was for that protein, and the carrier mRNA was BCL2 mRNA and MCL1 mRNA. So the mRNA for the two proteins that we want to get rid of never get translated if we keep them in the nucleus. Likewise with venetoclax, there's been, with selinexor and eltanexor, there's been evidence that we showed again here that P53 can be upregulated, and P53 leads to degradation of MCL1. So there's a couple of mechanisms by which this could potentially happen. So we tested eltanexor, which is a new generation of selinexor. It's another irreversibly binding selective inhibitor of nuclear export with venetoclax, and you could see the combination index is impressive in these 3 cell lines, and we had very nice results in vivo when given these 2 drugs in the blood in A and in B in the bone marrow and the spleen in multiple replicates. And like I said before, MCL1 in all 3 cell lines went down in the combination of eltanexor and venetoclax, and P53 went up markedly, or at least was the same with eltanexor alone in all 3 lines. And the cleave PARP went up in this experiment. So The question then is, what can you combine with venetoclax to engage this MCL1, BCL2 inhibition? And there's 2 trials going on right now with flavoperidol and dinucyclib, both 2 very different drugs that have some weak anti-MCL1 or have some MCL1 inhibitor properties. Excuse me. Those trials are sponsored trials being run by AbbVie. We have a trial looking at selinexor combined with venetoclax in all heme malignancies. And selinexor, which is a pretty toxic agent, if given too frequently, we've dosed way back to once a week, which has been seen to be very tolerable in patients with large cell lymphoma and myeloma and maintenance who are getting that drug now. Ultimately, we think true selective MCL1 inhibitors combined with venetoclax is going to be fantastic. It remains to be seen what the therapeutic window is. We're certainly involved in a lot of that work. We're interested in our series because we think we have a chemically superior series. Don't ask me to defend that as a non-chemist, but you can ask Dr. Fezzik. But there's several programs at Amgen, AZ, AstraZeneca, and Novartis, all with competitive MCL1 inhibitors, and AbbVie has recently launched their own renewed MCL1 inhibitor program. So maybe by inhibiting anti-apoptotic proteins in this manner, we can, in a mutation-agnostic fashion, eliminate for long-term the leukemia clone, at least eliminate the size of the clone to where the immune system can conduct surveillance and keep it in check. A bit akin to how we do with BCR-ABL treatment with TKIs and removal of TKIs, where now 50% of our patients on clinical trial and we are seeing in our clinics remain off therapy 6 months to a year later. Much like patients who receive CAR T cells with a construct that should go away, like CD28, remain in disease long after that construct is gone because the disease burden is reduced to the point where a now acquainted immune system can regulate the remaining disease burden. So I can't emphasize enough how exciting this is. This is kind of like being in lymphoma when Rituxan was coming out, or being in myeloma 5 years ago. This is really a great time to be a student studying leukemia. It's a great time to be a practitioner and clinician taking care of these patients because we can look people in the face and tell them, we can treat you, we're not going to hurt you, and there's a very good chance we can keep this away for years or ever. And I will have to say that your folks here are, again, at the tip of that spear. That's a military saying. It means you're at the forefront of developing this and really contributing, not to sound too corny, but to humanity in a very important way. I think that this paradigm shift is keyed around understanding and manipulating this family of proteins. And we can't forget the science, and we can't go back to doing clinical trials blithely and not thinking about the populations that we choose. Single-agent BH3 mimetics are likely going to fail in most patients. It might be that it's your way. It might be with priming and smart priming alone. It might be with combination of inhibitors of other BCL2 family members. That remains to be seen, but we're going to enjoy working together on that. So Haley Ramsey would kill me if she knew I was showing this picture of her because she's probably the most fun-loving, goofy, wonderful person, and this is a very severe-looking picture. But she's fantastic and has done the majority of the work that I showed you. All the people in my lab contributed. Scott Hebert is really a friend and mentor, has helped guide a lot of the work for a poor man scientist as myself, trying to translate things from the clinic, and I've helped him try to understand what's relevant coming out of his lab. Steve and Takyu Lee, his assistant professor, main medicinal chemist, driving this series, and really a Burgonian relationship. I've known Dan for 5-6 years. I've known Craig for a decade, and always been friends and trying to find ways to work together. But I think now we're kind of on the precipice of the timing being right and a Burgonian relationship academically there. And then Stephanie and Richard at Yale, who developed the Mr. G mouse, where we're growing MDS. I didn't show you this data, but they're very important collaborators, developed a mouse that allows us to grow a low-risk MDS. And then all my funding sources are listed here that contributed to this project. And of course, the patients for which without them we wouldn't have samples, and for them we're honored to do all the work that we do. Thank you. I'm happy to take any questions. Sir.
Clearly it's going to take combinations, like you mentioned, but it's like, for example, with Dan's trial, and even with the other trials, AZA and decitabine were just kind of for historical reasons. There wasn't really a rational reason to put those together with the ABT-199. And I'm wondering if there's going to be a rational way to come up with combinations instead of even just screening through them all, because there's an infinite number of combinations.
So the question was, for those of you back who didn't hear, was the trials with hypomethylation agents were kind of like, let's just do it because that's what people do for old people with leukemia, and it turned out to work, and lucky us. So how do we generate new clinical trials that are more rationally designed? So I'll kind of partially disagree with you and say that there was preclinical data that indicated not only would they work together, but some rationale. Because remember, DNA methyltransferase inhibitors are not just epigenetic molecules, they're also chemotherapy. And I tell my patients, you're getting like 10%, 20% chemo. And the rest is epigenetic. And they say, what's that? And I say, don't worry about it. It's the good, it's the part that doesn't hurt your DNA as much. But the idea of priming for, this is all venetoclax, man. It's just a question of whether or not the cells are primed to die. And if you can prime them with AZA or peanut butter, it doesn't really matter. It's whether they're primed to die. So I think it's rational in that way. Now, your folks are generating all kinds of cool metabolic data to kind of say, not only is it rational, but here's how we actually do this. I'm very practical. So I lead this 727 study, which is decitabine, not AZA. And I developed CC46 as well, and that's got different problems. That's the oral AZA. But oral decitabine now we have in a pill in a chewy center with a nice cover of a cytidine deaminase inhibitor. So they take the pill, the cytidine deaminase inhibitor shuts off cytidine deaminase, and then they just got IV decitabine. So it's so simple, it's brilliant. CC46, you have to give so much azacitidine to overwhelm cytidine deaminase, you end up with GI toxicity, and your methylome changes, right? Because you're giving these big doses over long periods of time. But anyway, Aztec 727 to me is a practical thing. This is I got patients on this drug 3 years who drive 4. I'm like you guys. I have patients who come, well, I'm not like you guys. I'm not near grizzly bears and zinky and everything out here. But I have, patients who still drive 4-6 hours to get to me very commonly. And to sit in a chair for azacitidine is not in the cards. And even if they get their azacitidine back home, that's 3 hours. If it's AZA sub-Q, maybe 2 hours at the cancer clinic every day, 7 days a week, 7 days of that week, every month for the rest of their life if they progress or have intolerance. So an oral agent to me is where it's at. And how to dial that in there's a lot of science left that needs to be done there. I happen to think that, inhibition of MCL1 with specific MCL1 inhibitors has got a lot of legs, but I'm going on a limb because we haven't shown the therapeutic window. We may be hurting normal cells, and we've got necropsies in mice that look okay, but, it's very much, this MCL1 inhibitor series that we have is 10 times more sensitive to human MCL1 than mouse. So it's a tough thing to test in a mouse, unless we super dose, and we're doing those experiments now. And we also are testing the effects on the heme compartment by doing regular hematopoietic transplant into mice and seeing what kind of cytopenias we see in the immunized mice with the MCL1 inhibitor, because it will have effect on the human hematopoiesis in the mouse. Ma'am?
I have kind of a similar question, I think.
Well, good, I got that one.
Yeah, well, it was partially answered, so that's good. So, for those of us whose grants get critiqued for not having, even the concept of an awesome therapeutic index. I was also thinking, when you think particularly about MCL1 and BCL2 inhibition, it just sounds, in principle, really non-specific to AML anyway. And you sort of answered that you're not really sure yet. But how do you think? Do you think it's worth worrying about therapeutic index aside from just empirical observations and preclinical?
Okay, well, Yeah, I think it's worth worrying about therapeutic index because MCL1 is an essential protein for cardiac myocytes, and there is a theoretic risk that we could cause cardiac damage. And anytime you have, in drug development, you hear cardiac and liver, you better do your due diligence. So I think we do have to define that. Your other part of your question is very interesting. This is the argument I have as a leukemia guy is, no, you really don't want to go into that big lung cancer market, Mr. Bowringer. You want to go into leukemia. And you want to do that because we have accessible tissue and we can do all kinds of cool science, and then you can go into lung cancer. I have no reason to think, as a clinician and where my bread is butter and where my interest is leukemia. But this is I think, tumor agnostic situation. I just know less about that, so I didn't show you those data. Rebecca Cook has got very nice data with the same inhibitor in breast cancer. Has been published in Molecular Cell. There was 700 different cell lines we tested against with our MCL1 inhibitor, and there's a series of small cell lung cancer lines that are all susceptible, so that's being explored because that's a great medical need, not very good therapy, and a huge market for these drug companies. So they're interested in looking at small cell lung cancer. So I think the long-winded answer to your question is it's probably disease agnostic, but I'm a leukemia guy, so I see it all through those rose-colored glasses. And I will argue that, because the translation is so important, we just have such better access to tissue, and we're a decade ahead on understanding the molecular genetics of leukemia than we are with, maybe that's shrinking, not a decade. I shouldn't say that. There might be breast cancer people here are offended. But anyway, we're a little ahead because we've had this accessible tissue, and because we have this very nice peak with MDS and AML where 95% of the mutations occur in 40 genes. And, these poor sessile polyp people in colon cancer and melanoma and lung cancer have this huge, long, drawn-out sessile polyp, if you will, graph of 250 genes being in the 95th percentile.
I was just genuinely curious. Do you mean specific to AML with respect to healthy tissue or with respect to other cancers?
Well, yeah, in particular, I was thinking about the conditional knockout of MCL1, which was everything. Not just cardiac tissue, but a lot of cells do that. And I'm always surprised by how many things empirically work well.
So that point is so well taken, and I think it's a battle in drug development between, hey, let's do really good science, and sometimes empiricism works. And the best example for one of the best examples of kind of the double edge of that sword is the development of HDAC inhibitors. So if anyone's ever treated patients with HDAC inhibitors, they're nasty in the clinic. But you find people preclinically, and they're like, these are the best transcriptional regulator drugs you ever see. They'll kill all these AML cells. They're fantastic. And so there's lots of rationale to use it. And then it just, we don't really, how many prescriptions do you write at the University of Colorado for penobitastat? Can you count them? It's point's very well taken. Sorry, she addressed it better than I did.
Michael, there's a recent paper from Jeff Tyner at Oregon, and they basically took a huge number of AML specimens and a huge number of drugs and a huge amount of screening, and the answer in the end was venetoclax plus something was by far the best. It was totally empirical, right? But there was many different things, as you alluded to, that combined well with the venetoclax. So I think, comment on the question, I think it's a critical issue in the field right now to ask the simple question. Are all these combinations working through a common mechanism? Or are we actually killing AML cells by differing mechanisms, and then that opens up all kinds of common growth possibilities? So that's sort of something that I think we're certainly trying to tease apart. My question, though, comes back to the use of venetoclax in the context of de novo versus relapse specimens. And the paradigm that you showed of giving one inhibitor, waiting for resistance, and hitting with another inhibitor. The question I thought James was going to ask is, the nature of the resistance that emerges is a function of the initial challenge. So you've seen this reciprocal relationship. You treat with one inhibitor, you get resistance, or you get sensitive to the other. When you treat with both simultaneously, what's the nature of the relapse that comes out of it? Do you know?
So we don't know that. That's the next paper. So as we kind of go up on the dose for the MCL1 inhibitor and try to define this therapeutic window, we are collecting cells from these mice and defining their BH3 profile. I saw Jeff's paper too, great paper, and the point is it's not so much this synergy with this pathway. It's more just like it's like turning David Banner into the Hulk, right? Venetoclax just needs some like Holt juice.
But is
Anger.
genotoxin a key? I mean, in other words, genotoxin is that because a lot of the drugs are genotoxins, or is it really, will it even synergize with the TKI and so forth?
So if you go back to the hallmarks of, So if you go back to the hallmarks of cancer, and you believe that you can kill the cell through through mimetic, then it might be that you disrupt apoptosis enough that that's all you kill it by. We don't know. So to your point, I totally agree. There's probably lots of different ways to inquire about this. Your method to do this is through a tumor metabolism method. Mine is largely based on identity through BH3 profiling, but we'll see.
Kind of related to that. So, are all of these cell deaths dependent on P53? And what do you know about P53 status?
Yes. Yeah, so that's the next paper. So we found some interesting things with P53 that I dared not present. I dared not send to the paper we sent to Blood with the sign venetoclax work because we got to figure this out. And Jennifer Pietenpol, who happens to be our cancer center director, studied with Bert Vogelstein. She's a P53 person. So there's a postdoc in her labs who's trying to help us figure this out in P53. If you ever work with P53 directed drugs, it's so complicated because there's P53 overexpressors, there's P53 mutants, there's P53 nulls, and there's different, there's MDM2 inhibitor, NUT1 inhibitor, different kind of ways to attack this. I don't know the answer to your question. I think P53 is ultimately very important. The data we have is what's largely sign, and I'm not sure what happens with venetoclax and resolution of defects in P53. And I'm not sure if anybody really knows. I don't. Okay, well, thank you very much.